Hello and welcome. Today's presentation is on the debate that is going on in the management of COVID pneumonia. This debate has divided the intensive care community right down the middle. The debate is whether to intubate or not to intubate. This debate was started based on the editorial that was published by Marini and Gattinoni in JAMA. In this, they showed there are two phenotypes of COVID-19 pneumonia, that is a L phenotype and a H phenotype. In the L phenotype, what you find is a essentially normal CT scan, but the PF ratios are less than 100. But the H type is a more typical ARDS type of picture where you have infiltrates bilaterally in the CT scan and you have lower PF ratios. So what they advocated in these cases is an early intubation. This intubation had to be done early to prevent lung injury. So we will discuss the points against early intubation, which were published by Tobin et al., in which they cautioned against early intubation and mechanical ventilation in COVID-19. So the first thing they raise the question against is the idea of patient self-induced lung injury, or the P-SILI. P-SILI is thought to parallel a ventilator-induced lung injury, an entity which has been supported by decades of experimentations and randomized controlled trials. In contrast, the patient-induced lung injury is something which has surfaced very recently over the last 4 to 5 years, and there are very few papers to establish the role of this entity in clinical practice. So some of the papers which have shown this particular entity, the first one is the paper published by Mascheroni in 1988. In this, they induced pharmacologically hyperventilation in animals. They did this by infusing salicylate into the brainstem of a spontaneously breathing sheep. And then the authors claimed that the subsequent threefold increase in the ventilation produced a lung injury, and this lung injury was prevented by mechanical ventilation. The tidal volume, the focus of authors warning against P-SILI, increased from 178 to around 250. If we look this tidal volume in terms of humans, it comes to around 500, which is much less than that is experienced by healthy pregnant women. The second important study that is highlighted is the failure of non-invasive ventilation in de novo acute hypoxic respiratory failure, the role of the tidal volume. In this, the authors concluded that high tidal volumes predicted a need for endotracheal intubation, and patients ultimately intubated were always significantly sicker than those not intubated and more frequently immunosuppressed, had higher SAPs and a lower PF ratio. The need for intubation was more likely precipitated by severity of the underlying illness rather than the tidal volume size per se, which was found to be a marginal predictor. The tidal volume in these two studies do not really constitute a sound scientific basis for the occurrence of P-SILI in patients with COVID-19. Now, how do we actually assess whether the patient's effort is getting too much in non-invasive ventilation? For this, Gattinoni and co-authors recommend inserting an esophageal balloon as a crucial step. They specify that when esophageal pressure swings increase above 15 centimeters of water, the risk of lung injury increases and therefore intubation should be performed. However, there is no experimental data which exists to justify this assertion. This is clearly based on their own thinking rather than any experimental data. So, to summarize the findings by Dr. Tobin, when we learn that a patient is acutely and persistently hypoxemic despite supplemental oxygen, we immediately consider steps to institute assisted ventilation. It is not possible to pick an oxygen saturation breakpoint at which the benefit of mechanical ventilation will decidedly outweigh its hazards across all patients. The presence of an endotracheal tube brings with it a wake of slew of complications. Each day of mechanical ventilation exposes the patient to these complications and increases the patient's mortality. Recommendations based on P-SILI for intubation and discontinuation of mechanical ventilation of COVID-19 patients, it is particularly radical and it is not supported by any experimental data. So the authors concluded that even if high tidal volumes and P-SILI may play some role in the progression of respiratory failure in COVID-19 patients, for which there is no convincing evidence as of now, this would not provide a justification for liberal use of endotracheal intubation, for which there are decades of research documenting fatal complications. So in this presentation, we looked at Dr. Tobin's view and the idea of not to intubate COVID-19 patients. In the subsequent presentation, we will look at Gattinoni's view and why we should intubate the patients. Thank you for your patience and check our website for further information.